Ellis. I'm a board member of the Women's Fund of Greater Milwaukee, and I'm so glad that you're joining us to take a civic break. This year, the Women's Fund is celebrating our 40th anniversary, which is amazing. For 4 decades, we've been at the forefront of the women's movement locally, mobilizing philanthropy, challenging the status quo, and bringing people together to advance gender equity in our community. So today's civic break topic is about expanding care, and that really connects back to the Women's Fund advocacy work, particularly our focus on advancing policies and systems that enhance women's health and well-being. You can see our full advocacy platform on our website. But the Women's Fund stands in support of comprehensive, inclusive, and evidence-based strategies that prioritize the well-being of women at every stage of life. We do believe that women's health is not just a single issue, it's truly an ecosystem that's influenced by social, economic, environmental, and biological factors. And to build a society where women can truly thrive, we have to address the systemic barriers that and foster conditions that support our health, our dignity, safety, and equal opportunity. Also, the intention of the civic break is that we know that many of us are feeling overwhelmed by the volume of information and the pace of the news cycle, and this series is really designed to help expand our understanding, provide some context, and maybe even offer some, informed talking points that you can use to navigate some of those difficult conversations with confidence. So now I get to shift to today's topic. Today's civic break focuses on perinatal mental health and maternal well-being, including the realities that many women face during pregnancy and the postpartum year, and the policy changes shaping access to care in Wisconsin. We are joined today by Sarah Orns Bloomquist, Executive Director and co-founder of Mom's Mental Health Initiative. Sarah is a certified family life educator and is certified in perinatal mental health. Through her work as an advocate, a speaker, and a leader, Sarah brings both lived experience and clinical expertise to conversations about maternal mental health, disability, treatment access, and also systems change. Sarah, we are so grateful to have you with us today to help us better understand the landscape of perinatal mental health, what the current data is telling us about risk and access to care, and why these issues matter so deeply for women and families across Wisconsin. So with that, let's take a civic break.
Thank you so much for that introduction. Please let me know if you can't see my screen, or if there's any troubles going on. Okay, great. Any tech issues, there always seems to be something that happens. But my name is Sarah Orns Bloomquist, and I am the co-founder and executive director of Mom's Mental Health Initiative. We are a grassroots nonprofit that was started 10 years ago by me and my co-founder. And really, we started this organization because we found it so difficult to access the right care when we were going through a perinatal mental health condition. And so I'm going to get more into what is a perinatal mental health condition, why access to care is an issue, and some of the policy around that. But just so you know, our mission is to help those navigating perinatal mental health conditions by sharing information, connecting them to resources, and providing peer-driven support. So at the core, we are a peer organization. We operate as peers. We're not clinical. We don't give medical advice. We don't diagnose. We're purely providing peer support and connecting people to evidence-based treatment as well. Just a note on our name. When we started this 10 years ago, my co-founder and I were just two moms who had suffered through our own experiences. We both worked in the helping profession, and we were just excited to be able to do something. And but we recognize that not every birthing person identifies as a mom. We also recognize that you don't have to be the mom or the biological parent to experience one of these conditions, and just that we remain an organization for all, that all identities and sexualities are welcome. So I'm going to start out with Karen's story, the beginning of her story. And she shared that by the time I realized I was in full-blown postpartum anxiety, I was struggling and couldn't wait. I wasn't sleeping and was crying throughout the day while trying to maintain my career. And I was suffering from panic attacks. I couldn't get through to my primary doctor, and her nurse told me on the phone I couldn't take any medications because I was breastfeeding, which is not true and is misinformation. I tried my OB. They told me to get counseling and to see my general MD. I tried my MD again, and she was on vacation for a week. I was suffering. My work was failing. Things started falling apart at home. I tried finding a psychiatrist, and none of them were accepting new patients for 6 months. This is a very common experience for women suffering from a mental health condition when they're pregnant or postpartum. Access to care is a very difficult process to navigate, and often results in misinformation, poor care, and long wait times. So what are perinatal mental health disorders? Well, they are mental health conditions that start anywhere in the pregnancy period to roughly a year or so after. If left untreated, it will last longer. But again, we're looking at that perinatal period. Perinatal mental health disorders are really defined by looking at frequency and functioning. So are these symptoms, these mental health symptoms, something that won't go away on their own, that they're persistent, they cause impairment, they're very distressing to the parent, they can cause emotional suffering? And how is that impacting their ability to function every day? Is it making it hard to carry out tasks and responsibility at home, at work? We often hear about the baby blues, which is a very common experience within around 2 weeks postpartum. You might have the weepiness, you might have some anxiety, sometimes these hormone surges, but it's not affecting your ability to parent. You're still connecting with your baby. You're still able to experience some joy, and your functioning is fine. When it goes beyond that, then we are looking at a possible mental health condition. I love this image because it really portrays what some people look like. You can't tell on the outside, but on the inside, there's suffering. I had a mother who lost her daughter to a perinatal mental health condition at 1 year postpartum. And she said this is exactly what her daughter looked like. Fine on the outside, experiencing terror on the inside. Well, what we know is that these are very common, these mental health conditions, and they can happen anywhere, like I said, between the pregnancy and postpartum period. And it happens to about 1 in 5 women or perinatal people that we know of. This is what's reported. How many people do not report what they're going through or realize what they're going through until much later on? So 1 in 5 might go through it. It's a spectrum of severity, and there's a lot of different conditions. I really like this quote by Walker Ladd when she said, "How long have women waited to hear that postpartum depression is traumatic and survival a small miracle?" When I read that quote, I felt very seen because that was my experience. It was very traumatic, my postpartum depression and anxiety. It really impacted my ability to be the parent I wanted to be. And I suffered longer than I needed to. And it was traumatic. And the sting of it lasted a very, very long time. So perinatal mental health conditions, you're probably more familiar with the term postpartum depression. That can be used as a catch-all phrase, but really it's not. It's one of many conditions that can happen in this umbrella term, perinatal mental health disorders. Sometimes they're also referred to as PMADs, perinatal mood and anxiety disorders. I prefer to use perinatal mental health disorders because that encompasses substance use disorder as well. But again, in the perinatal period, pregnancy up to a year postpartum, you can experience depression, anxiety. Lots of times they coexist. There may be OCD, PTSD, panic disorder. There can be bipolar disorders, which can be very serious if left untreated. And there can be pregnancy and postpartum substance use disorders, and then postpartum psychosis. And oftentimes in a publicized psychosis situation, they'll call it postpartum depression, and that's not the same thing. You can learn more about these terms on our website, and we go through all the different types of symptoms that can creep up during these conditions, and we try to use it in mom jargon. We try to use it in everyday terms, not clinical, so people can really find the words to describe what they're feeling, because it's very hard to be able to put to words what's going on. Many times it's hard to recognize because it's really affecting their thought process. Somebody's thought process, the depression, the anxiety, it distorts the truth. And they might think, what if I'm just not cut out to be a mom? Yes, I think we all have that thought once in a while, but these are persistent thoughts. These are creating so much self-doubt. These won't stop. Everyone else seems to be handling this better than me. What's wrong with me? Why can't I do this? I feel guilty all the time. Shame and guilt is just rampant. I can't stop worrying that something bad is going to happen. The sense of impending doom, really fearful about things that can come or happen. And then sometimes they turn into these thoughts of harm coming to you or your baby, sometimes at your own hands. Those are called intrusive thoughts. They aren't acted upon. They're just thoughts, but sometimes people go to extreme lengths to make sure that these thoughts don't happen, like making sure they're not left alone with their baby. I had a mom who always kept her kids outside with her because she felt if she went crazy, somebody would see it happening and do something. Very overwhelmed, isolated, exhausted, but they can't sleep. Their sleep is impaired. When they're allowed to sleep, they cannot sleep. What's wrong with me? Why am I not enjoying this time? And a very frequent thought is maybe my baby would be better off without me. That is not necessarily a suicidal thought. It is not necessarily anybody who's making an intent to take their life. It's more of I'm failing as a mother. I'm not doing what I should be doing. I'm a burden. Everyone would be better off without me. So how do these conditions intersect with disability? Well, a disability is a physical or mental impairment that limits one or more major life activities. When we think about what a mom has to do when she has a baby, she's engaging in many life activities, right? The mental health conditions, they can affect her thinking. They can make it hard to concentrate, problem solve. Sometimes it affects their language, hard to find the words, very foggy brain. Also, it can affect and impact how they care for oneself. Are they taking care of themselves? Are they able to take care of themselves? Are they able to take care of their baby? For me, when I had my son, every time I went over to pick him up, I felt this extreme overwhelm, almost to the point where I couldn't pick him up. The anxiety was so bad. But I did do it. But it was very hard. And at times, especially with my daughter, I had to have my parents care for her, at least in the first half of the day, because my anxiety and depression was so bad, I couldn't do it. So impacting the ability to be a caregiver. What about at work? How is your attendance? How are you being productive? Are they engaged in their work and interacting with others? Maybe people aren't engaged. They're drawing in. They're more isolated. Parenting a newborn can be a very isolating experience. You add a mental health condition on top of that, and you can really suffer with even more loneliness. And then just being able to perform daily activities like sleeping, eating. I had no appetite. How people are managing their stress. Again, these conditions, which can happen in the pregnancy up to a year postpartum, can be very debilitating and are considered a mental health, are considered a disability. So these moms, these people going through this have rights, and they need to know what their rights are. Who might suffer more from a mental health condition? Well, we know there's more risk if you had a prior mental health condition. If you're a survivor of intimate partner violence, maybe you're on Medicaid. More minoritized populations, including the LGBTQIA community, women with disabilities are at a higher risk, military moms, parents who have a history of infertility, or maybe they've had loss, pregnancy loss, traumatic births, which trauma is defined by those who go through it, not by the doctors or those who are observing. And traumatic births and obstetrical violence are very prevalent. Up to 30% of American Indians and Alaska Natives suffer from postpartum depression, and up to 40% of Black and Latina moms suffer, which is twice the rate of their white counterparts. We also know that Black women might suffer twice as likely to suffer, but they are half as likely to receive treatment. That has to do with access to care, discrimination, in the healthcare system, by the healthcare system. It also can do with poor access to care, a lack of trust in the healthcare system. And you could have no risk factors and still experience one of these conditions. You could have multiple risk factors and not experience one of these conditions. So there isn't necessarily a rhyme or reason. We just know that there are risk factors. So what's the data look like? Well, we have learned through our maternal mortality review teams, Wisconsin has one, many other states do, that mental health conditions continue to be the leading cause of pregnancy-related deaths. 38% in Wisconsin of all pregnancy-related deaths were caused by a mental health condition. 88% of those were due to overdose. We also see deaths are happening later in the postpartum period, around 6 to 9 months postpartum. How many people are still seeing their OB at 6 to 9 months postpartum? And the vast majority of these pregnancy-related deaths are preventable. One statistic we have is that it costs about $32,000 per mother-child dyad. It costs society that much if left untreated. So if we look at the birth rate in Wisconsin, we look at the $32,000 that it costs, and we also recognize that 75% of those who screen for this do not receive treatment. That costs our state over $100 million. So what else is the high cost of not treating these conditions? Well, they can cause negative childhood development outcomes. When we are not treating our mental health, it can cause more ER visits, more neglect, and also impact bonding, attachment. These can cause lifetime conditions and developmental challenges. We also see that depression and severe anxiety in the pregnancy period, when left untreated, can cause preterm birth and babies with low birth weight, which can also impact childhood developmental outcomes. And like I said, about 100,000, over 100,000 million it costs our state of Wisconsin to not treat these. Loss in workforce, more reliance on public health benefits, more healthcare usage. But as a country, it's $14.2 billion. So the Wisconsin landscape. Wisconsin, unfortunately, has been very behind when it comes to addressing access to care for those suffering during the perinatal period. We were one of 2 states that did not have postpartum Medicaid expansion. So benefits, your postpartum Medicaid benefits could be lost at 2 months postpartum, 60 days postpartum. Remember when I said that the majority of these deaths are happening 6 to 9 months postpartum? We got involved probably almost 5 years ago of really advocating for postpartum Medicaid extension. It was going on in other states. They were seeing birth outcomes improving, but it would never be taken to a vote. Even though there is full bipartisan support, the full Senate agreed to this, but it wasn't taken to a vote in the House. This spring, it finally, at the midnight hour, was called to a vote, and it passed with flying colors and was extended to 12 months postpartum. It was a glorious day for those of us who have been fighting for this. This just means that moms are getting listened to more, that we're seeing that taking care of people in that time period is a benefit to our society. It's a benefit to our community. It's a benefit to our families. This law should go into effect in July, and we'll wait and see how it goes. So what are the benefits of this extension? It can support fuller recovery. We don't fully recover in 6 weeks or 60 days from having a baby. This extends that recovery period. It provides continuity of care and screening supports. So moms can be screened not just at that 6-week checkup, but at other points down the line in their postpartum period. It makes it so that they don't have to lose their eligibility and reapply at 60 days. Find new doctors, find new providers. We know that a healthy mom means a healthier family, a mom who can function and be that mom that they want to be, allows children to thrive. It reduces those long-term costs that we know from lack of treatment, and it can reduce death, the risk of death. And it increases connection because people are still engaged in their healthcare process, and therefore that isolation can be reduced. But there are still gaps. We know that coverage does not always equal access. We look in our rural communities. We have a shortage of providers in the rural communities. We have hospital closings. We have labor and delivery wards closing. We also know there are just not enough providers who specialize in perinatal mental health out there. That's something Mom's Mental Health Initiative does, is we work very hard to find those providers and screen and vet them so that we can quickly connect somebody to proper treatment. Basic needs are not being addressed. If you have transportation issues, housing issues, if you cannot find childcare, that impacts your ability to access care. It also does not cover doula support or peer support, and those are crucial into reducing disparities, reducing potential negative outcomes. We really want to get those things covered by Medicaid. And just, we know systemic inequalities continue to exist. So what's needed based on this maternal mortality review team and many organizations, including ours, and we serve on the maternal health task force? We need to improve access to treatment. We need more screening, more referrals to substance use disorders clinics. We also need to stop criminalizing substance use disorders. People have so much shame, fear their child being taken away. They don't seek help. We want to reimburse peer support. We want to expand perinatal psychiatry access. We do have a perinatal psychiatric access program called the Periscope, which is wonderful. We just want more providers to use it. Invest in community-based maternal mental health organizations. We want a culturally responsive workforce, and we need to be educating our providers more. So remember Karen? Desperate, she reached out to her local breastfeeding group. She said, one girl referred me to MMHI. I was referred to a doctor and was seen the next day and was able to start on medication right away. Within a week, I felt better. Within 2 weeks, I felt great. I could not afford to wait for anyone once the PPA hit, and no one else should have to. Thank you for your time. Please reach out if you have any questions or want to learn more about our services.
Fabulous, Sarah. Thank you so much. There was so much information that you shared. We really appreciate your expertise. It was well done, well organized, and really a terrific overview of the issue. I think it's important to note that mental health is invisible as a disability, and I think some of that invisibility of it makes it really difficult for people to really show compassion and understanding. So I think having awareness that such a mental health can exist, even when it's supposed to be a happy time for families, can be really a burden. So thank you so much for sharing your expertise and your time this afternoon. I want to thank also everyone for participating in today's Civic Break. I will just alert you to our next Civic Break is scheduled for Thursday, June 18. While we don't have the specifics, the registration is open and the link is available to put on your calendar. It will be focused on the executive branch of the Wisconsin state government. So please put that on your calendar, Thursday, June 18, of course, 12:30 to 1 p.m. As a follow-up to that, we also have the Women's Fund Laundry Night scheduled for Monday, June 29th. I know usually we have the Civic Break and then the Laundry Night because of Memorial Day and the schedule for today's Civic Break. Laundry Night was yesterday, so if you were thinking you were going to go to Laundry Night this month, it's over, but you can certainly put Monday, June 29th on your calendar. That information is also on our Women's Fund website. And I will just extend, we are having a informational reception on Wednesday, June 10th. Beth Odian is our board chair, and she is hosting at the Michael Best office at the top of the BMO Tower, downtown Milwaukee. If you're interested in joining us to learn a little bit more about the Women's Fund and our agenda, and possibly consider financial engagement, we welcome everyone today. If you want to just send me a message to say you're interested, I can send you the details. That's a 5:30 start on Wednesday, June 10th. So with that, as we approach the one o'clock hour, I will close today's Civic Break, and I will just stay on in case there's follow-up conversation, but let me conclude this officially.